Hi guys, welcome back to the channel. Today we are going to be talking about heart failure. The main thing to know about heart failure is that heart failure is not just a disease, it's a syndrome. In other words, it's a collection of symptoms that is caused by the heart's inability to pump blood effectively. Now think of it as a tap, and imagine the tap is super weak and is not able to bring out the required amount of water to fill or to provide water for the family or whatever. That's basically what happens with heart failure, but in this case using blood as an example. There are different types of heart failure. We have heart failure with reduced ejection fraction. Now basically think of ejection fraction as the amount of blood that is pumped out. That's the only way I can describe it easily to you. So now reduced ejection fraction, the ejection fraction is less than 40%. That means the heart is very weak, or the heart pump is very weak. Then we also have heart failure with preserved ejection fraction. That is when the ejection fraction is greater than 50%. The heart is just stiff and non-compliant. That's the reason for the failure in this case. And then we have heart failure with intermittent ejection fraction, whereby the ejection fraction is between 41 to 49%. Now we also have the classification based on onset, whereby we have acute or chronic onset. Now, for us to continue, it's important that we have to understand the pathophysiology. What exactly causes this vicious cycle? The first thing to note is that heart failure can occur when there's a decrease in cardiac output. Whenever there's something that causes a decrease in cardiac output, it will cause reduced perfusion to organs. Now, this will result in the activation of the sympathetic nervous system and the RAS system, which is renin-angiotensin aldosterone, whatever. Now this will try to compensate, but in the process the heart failure worsens over time, because this is a compensatory mechanism. It cannot just continue over a long time. Now what happens at this point is that there's going to be accumulated fluid retention. Remember the activation of sodium, which would cause fluid retention basically, which will cause pulmonary and systemic congestion, which will just basically cause hypertrophy. So it's just a step-by-step process. A decreased cardiac output, which will result in sympathetic nervous stimulation, which will result in hypertrophy and pulmonary congestion. Now just think of it, there's a mnemonic for it. Like I said, failure, fluid overload to activation of RAS to increase heart workload to dysfunction, which will now cause inability to meet oxygen demand, and then remodeling of the heart. So then what causes heart failure? The biggest culprits are hypertension, coronary artery disease, valvular artery disease. I think in my case I usually use a mnemonic which is called HICDAM. Again, hypertension, ischemic heart disease, cardiomyopathy, diabetes, arrhythmia, myocarditis, etc. But then how do you remember these symptoms? How do you spot the clues? When a patient comes to meet you, how do you realize that, oh, this could be heart failure? It's divided into two. Remember I said we have the left-sided and the right-sided heart failure. Now, left-sided heart failure, think of the lungs. In other words, the lungs are affected. The symptoms are going to be more of pulmonary symptoms. So we would have, the mnemonic for this one is DOCHAP. I'm going to write it on this. DOCHAP. In other words, we would have dyspnea on exertion, we'll have autopnea, we could have crackles of fluid in the lungs, we would have, this is sign of pulmonary edema, we would also have hypertension, we would also have activity intolerance, that's fatigue and weakness, and then we would also have paroxysmal nocturnal dyspnea, which is when the patient is not able to breathe properly during the night. Then right-sided heart failure, think R for the rest of the body. So in other words, the patient that's basically out my head. So the patient will have ascites, the patient will have weight gain, the patient will have hepatomegaly, the patient will have edema, the patient will have anorexia, and the patient will have distended neck veins. That's jugular venous distension. Okay. So the next thing we're going to talk about is the diagnosis. How do you diagnose heart failure? We use a step-by-step approach, just as like normal. The first thing you have to do is to do a clinical assessment. You're going to check history and physical exams. So the history is going to help you determine whether it's a right-sided or a left-sided heart failure. Remember what I said earlier, right-sided is rest of the body, left-sided is basically pulmonary symptoms. Then you also have to check the physical exam. Then you will also have to do your run investigation. You're going to run investigations like brain natriuretic peptide, that's the BNP. It's usually elevated in heart failure. It will also help you differentiate the other causes of the dyspnea, because if a patient has dyspnea, there are other causes or the other things that could cause it. Then you also have to do an echocardiogram. An echocardiogram is basically the heart, is the gold standard, because it's basically going to check if there's hypertrophy, and it's going to check the ejection fraction. It's also going to measure the heart function. Then we also have ECG to detect the ischemia or arrhythmia. We also have to do a chest X-ray to check for pulmonary congestion and cardiomyopathy. We can also do other tests like full blood tests, electrolyte, renal function, thyroid function, etc. So just to remember, we can call it B-chest, which is based brain natriuretic peptide. We can also do an echocardiogram, which is the gold standard. We can also do a chest X-ray. We can also do we also have to do history and examination. We also have to do an ECG. We also have to do other serum lab tests, basically, for it. And then we also can do a thyroid function test, but that's not usually done. Remember, if the BNP is high and the echograph shows that ejection fraction is 35%, remember, you have heart failure with reduced ejection fraction. If it's greater than 40% or 50%, you have heart failure with preserved ejection fraction. Basically, the categories. Are you seeing how everything comes together at the end? Now let's go to the management. How do you manage these patients once you've diagnosed heart failure? Your treatment is going to be determined on whether it is acute or chronic. So now let's start with acute heart failure. It is important to know that this is an emergency. The way to do it is the LMNOP approach. First of all, you have to give furosemide. Remember that there's going to be edema. The patient is going to present with edema. You have to reduce the fluid overload that has come in. You also have to give morphine for the pain. It's usually controversial, and it also helps, not for the pain, to reduce dyspnea. So you're going to give morphine, but this is a controversial approach and it's not really done all the time. Then you have to give nitrate to reduce the preload. Then you have to give oxygen if hypoxic, and then you have to tell the patient to sit up. Ensure that this patient is sitting up. Very, very important. Now, in chronic heart failure, you have to look at it as for a long-term management. So that is basically the ABCD approach. First of all, you're going to have to your lifestyle is going to be very important. Low sodium diet, food restriction, etc., etc. But then the main thing is ACE inhibitors. That's, you're going to be talking of your valsartan, whatever, to reduce the mortality. You also have to use your beta blockers. You also have to use your conversion prevention. That's basically your aldosterone antagonist. That's your spironolactone. And you also have to do a diuretic. And then if it's severe, you might also have to use an ICD or a CRT. A CRT is basically a machine that helps to resynchronize the heart, like you're trying to adjust the ejection fraction or whatever. So it also helps with that. Now, in the treatment, you have to remember that you have to control the blood pressure and give diuretics, and also your lifestyle changes. Now, finally, your complications could be your pulmonary edema could result or cause respiratory failure. You could have atrial fibrillation or ventricular failure. You could have risk of thromboembolism. You could have kidney dysfunction, and you could have sudden cardiac death. Now let's do a quick recap. Heart failure is basically all about recognizing the left and the right-sided symptoms. You also have to confirm with your brain natriuretic peptide and your echocardiogram, because your echocardiogram measures the ejection fraction and it also measures the hypertrophy and your heart function. Then you also have to treat with the LMNOP approach for acute and ABCDs for chronic. Remember, LMNOP is your Lasix, is your morphine, is your nitrate, is your oxygen, and then your positioning. Your ACE approach is your ACE inhibitors, your beta blockers, your conversion prevention, and your diuretics. Now imagine a patient comes in with a question whereby a 65-year-old man with a history of hypertension presents with dyspnea, autopnea, and leg swelling. Now on examination, you see crackles, you see S3 heart sound, and you see pitting edema. The BNP is high in this case. Ejection fraction is 35%. What is your diagnosis? Ensure that you drop your answer. Do not look at it here. Ensure that you drop your answer in the comment section, and yeah, I'll pin the best one. Don't forget that the slide is available. The link for the slides are available in the description box, but you can only access it when you like and subscribe to the video. Thank you so much, guys, for watching. See you in the next video.